but I want to spend some time talking about patient education in cardiovascular medicine and its impact on medication adherence. Over the next 20 minutes or so, I hope to demonstrate the importance of improving medication adherence in cardiovascular medicine, describe one successful patient education program for improving medication adherence for prevention of venous thromboembolism, and then finally to highlight other patient education initiatives for improving medication adherence. So John, like I said, already talked to us about the crisis in medication adherence. But even the former U.S. Surgeon General C. Everett Koop raised our awareness of the problem about medication adherence when he said, drugs don't work in patients who don't take them. Poor medication adherence results in suboptimal disease management and prevention and burdens the healthcare system. Improving a patient's understanding of the rationale for prescribing a certain drug by explaining its benefits actually improves adherence. In 2011, the U.S. Surgeon General and the National Consumers League launched a very important medication adherence initiative called Script Your Future, which is designed to educate patients on the importance of medication adherence. And this is an example of that website. And this is the sort of splash page for that website. And it urges providers to talk to patients about medication adherence. And we'll look a little bit more in depth at this, this strategy or this improvement initiative in a bit. Medication adherence in cardiovascular medicine applies to many different disease processes. It's important for medical therapy after heart attacks, for management of high blood pressure, for management of diabetes, for venous thromboembolism prevention, and for heart failure management, among many other issues that we deal with in cardiology. So now I want to pause and focus on one particularly important patient safety issue, which is venous thromboembolism prevention, where there's an incredible unmet need for patient education. In 2008, the U.S. Surgeon General estimated that 100,000 to 180,000 PE-related deaths occur annually in the U.S. alone, and that pulmonary embolism is the most preventable cause of death among hospitalized patients. We looked at a study using a large national database, and I'll tell you a little story about this database in a second, but it's called the HCUP database. It's the Healthcare Utilization Project. It's a nationwide inpatient sample. And the story of this database is that John Finikos was actually working on this project for quite a while before I came on board full force with the Venous Thromboembolism Research Group. And the study that we did used a very complicated statistical model that incorporated all of these data and then would spit out projections of what would happen if we changed certain things in the model. So John had been working on this for about a year, and the model was very complicated, and getting everything to work and make sense took a while. And so Sam asked, why don't you work with John and see if we can finish this study? So John and I worked very hard with this study. We tweaked the model, we ran the numbers, and I started writing the paper. And I finished the paper, and I turned to John. I said, John, here's the paper. It looks great. What do you think? And he said, well, Greg, let me tell you the truth. I think we're going to get killed here. We'll submit it, but this is, we're going to have to run for cover after we send this in. So about 3 weeks later from submitting it, I get a reply back from the journal. I said, oh my gosh, that's so fast. This isn't going to be good. It's the shortest reviewer letter I've ever seen. It was reviewed by the section editor, and the section editor just wrote, very complicated paper, nice. And that was it. And I think a month later, John submitted a second part of this study and also had a very easy sailing. So it just goes to show sometimes complicated things can sail without difficulties. So in this study, what we did was we modeled what would happen to medical patients who had a variety of different medical problems like stroke, heart failure, respiratory disease. What would happen if we improved upon the currently known rates of venous thromboembolism prophylaxis and made them all 100%. Everybody who needed to get prophylaxis got it. And what we found is that if you could do that, and the patients got their medication, we could reduce the rate of venous thromboembolism in all of these patient groups by more than half. Now, that, of course, assumes that when you increase prescription of the medication, that it's going to be received and it's going to be taken by the patient. We did some quality improvement initiatives over the last decade to see if we could improve prescription of venous thromboembolism prophylaxis in the patients that need it when they're in the hospital. And one of the landmark studies that Dr. Goldhaber helped to design and put through was something called the electronic alert trial. And in this study, patients were randomized so that their doctors would receive this electronic alert that would show up on the computer screen while they were working on that patient's medication orders. And it would say that the patient is high risk for venous thromboembolism, but they're not ordered to receive any preventive measures. Please look at the options for preventive measures and choose something. And it gives them a choice to go ahead and write some orders for prophylaxis. It gives them the option to learn more about prophylaxis in this enormous guidebook that Dr. Goldhaber and I wrote, and that's available to all the doctors and other providers at the Brigham, or to exit straight to order entry. And what Dr. Goldhaber found was that this simple computer screen resulted in a significant improvement in the number of prophylaxis prescriptions for both mechanical prophylaxis and prophylactic anticoagulants. And even more important than that is this screen alone was responsible for a 41% reduction in symptomatic deep vein thrombosis and pulmonary embolism. That was subsequently published in the New England Journal. But unfortunately, there are barriers to all sorts of quality improvement initiatives for venous thromboembolism prevention. Now, John talked a little bit about how cost impacts medication adherence. Certainly, cost impacts the quality improvement initiatives that we try to design in the hospital. But provided we have enough money to put together these strategies, there are still important barriers. Poor medication adherence is one of the most important barriers, and I'm going to talk about that a little bit more. But there's also a problem of a lack of awareness in the need for quality improvement. If providers don't understand that there's a need to improve the performance of a particular area of care, they're not going to buy into a quality improvement initiative. In addition, we have to make sure that the quality improvement initiative is reaching the right patients. So there are low-risk patients that come into the hospital that don't require prophylaxis. We don't want to bother their providers with a message about increasing prophylaxis when those patients don't really need it. So what we need to do is we need to make sure that we risk stratify patients and make sure that the patients who need the message are getting it and that their doctors are also getting it. So John did a very important study which looked at medication adherence in venous thromboembolism prophylaxis. And this was part of a larger study called the Continuum of Care study. And what John found was that when he looked at medication adherence, which he defined as the number of doses received by the patient over the number of doses that were prescribed, that medication adherence was not as high as we would have hoped. For patients receiving low molecular weight heparin as prophylaxis for venous thromboembolism, there was a reasonably high medication adherence, but not perfect, about 95%. But for unfractionated heparin, there was a significantly lower than expected medication adherence of about 86 to 87%. And that was surprising to us, and John looked further into that to try to see why aren't these patients getting their medications. And it was thought initially that it might be because of a change of shift, nurses weren't giving the medication. But what we actually found was patients were refusing to receive these medications, and that was the predominant reason for a lack of adherence. And so we hypothesized that patients aren't adequately educated about the rationale for prescribing prophylactic anticoagulation, and further, anxiety and discomfort associated with injectable prophylactic anticoagulants constitutes a real barrier and contributes to this patient refusal. So with that, we decided to put together a patient education initiative as a prospective cohort study. We designed this study to assess the impact of an in-hospital, pharmacist-led, individualized patient education program to improve medication adherence to injectable prophylactic anticoagulation. We focused on patients that were at least 18 years of age, who were admitted to either medical or surgical services, and who were ordered for injectable venous thromboembolism prophylaxis. And these patients received a one-on-one patient education session that was conducted at the bedside by a dedicated research pharmacist within 24 hours of the first appearance of an order for injectable venous thromboembolism prophylaxis. This patient education initiative focused on several important areas regarding the need for prophylactic anticoagulation. First, it defined to patients what is venous thromboembolism. In particular, what is deep vein thrombosis and what is pulmonary embolism, and why should the patient care? Second, it explained what does the prophylactic anticoagulation do? Well, it prevents blood clots, and many patients want to know what are the side effects. Is bleeding a side effect of a blood thinner? And our pharmacist reviewed that there's a very low risk of bleeding associated with prophylactic doses of anticoagulation. And then finally, the education initiative stressed why is it important to take every dose. First, to avoid lapses in protection. And second, to make sure that we're protecting the patients and preventing venous thromboembolism. So here are the results of that study. First, on the left, we have the baseline clinical characteristics. And the important thing here is that what we identified was a patient cohort that was at very high risk for venous thromboembolism. Patients who needed a patient education and intervention like this. We use a venous thromboembolism risk score that Dr. Goldhaber validated in many previous trials. And we, in general, found patients with risk scores of above 3. That patient cohort is very high risk for venous thromboembolism. When we looked at the characteristics of the type of prophylaxis that they were receiving, we see that unfractionated heparin was used about 55% of the time, and then low molecular weight heparins were the other most common injectable prophylactic anticoagulants. One of the important findings of the study is that we were able to provide patient education within 24 hours of the first thromboprophylaxis dose in 99% of patients. So this is a feasible patient education initiative that should be able to be accomplished at most hospitals. One of the interesting things is patients had the option to ask questions after the patient education intervention. And very few patients actually took advantage of this question and answer session. But even more interesting than that is that among the patients who actually had questions, most of their questions had to do with their risk of venous thromboembolism after hospital discharge. That is an area of research that Dr. Goldhaber and I have focused much of our attention, and it was curious for us to see patients also focused on something that we think is important too, since there hasn't been much play in the literature about this. So when we looked at medication adherence, we found a significant improvement in medication adherence compared to the historical cohort that John worked on. Medication adherence improved from an overall average of about 89% to almost 95%. The percentage of patients receiving 100% of their thromboprophylaxis increased from about 62% to 74%. And then patient refusal, which is what we were really aiming at preventing, decreased from 44% to 29%. So this very simple patient education initiative was successful at addressing this issue of medication adherence. When we looked at patient outcomes, although the previous study didn't record patient outcomes, we had a very low rate of symptomatic venous thromboembolism at 90 days, and there were no patients that died from venous thromboembolism. Now I'd like to focus on some other patient education initiatives. Broadly speaking, there are many different strategies that can be taken to improve patient education. There are web-based educational offerings, such as the North American Thrombosis Forum and our website, and then the Script Your Future initiative that the Surgeon General has worked on, and I will show you more about that. There are patient education pamphlets, booklets, and articles. Some examples of that would be our upcoming North American Thrombosis Forum patient education pamphlet for post-thrombotic syndrome, and then the Circulation Journal's cardiology patient page. There are live patient education seminars, such as the one that we're attending right now, and those other ones put forward by the North American Thrombosis Forum, such as the Summit tomorrow. There are support groups, such as the long-standing Brigham and Women's PE support group, and then we all try to provide one-on-one patient education when we see our patients. So this is an example of the Script Your Future website. And this one shot actually explains a lot about the problem that we're facing in medication adherence. 1 out of 3 people never fill their prescriptions. Nearly 45% of the American population has 1 or more chronic conditions that require medication. However, nearly 3 out of 4 Americans don't take their medications as directed. And more than 1/3 of medication-related hospital admissions are linked to poor adherence. Altogether, this costs Americans about $290 billion per year. And so on this website, they really try to empower patients to understand that poor medication adherence actually affects their own health and their future. And there are lots of tools that patients can use on this website to help improve medication adherence. This is one of the things that patients can print and actually keep track of their medications, keep track of their allergies. And here, they can actually list their medications, describe them, write down how to take it, and actually chart their medication administration and adherence each day. Now, the current U.S. Surgeon General, Regina Benjamin, also mentions an important caveat when we think about patient education, and that is that as clinicians, what we say doesn't matter unless our patients are able to understand the information that we give them. So it's important in patient education to make sure that we're making it accessible and that we're focusing on the patient. Our North American Thrombosis Forum website is an important nexus for us to pass information on to our patients and to other providers. And in keeping in mind what Dr. Benjamin has said, we've actually made an important change to our website to help it be more accessible and more easily reached by patients. And this is an example of our new website. In the last few minutes, I just want to talk about some other initiatives that have been published in the literature for improving medication adherence through patient education. This is one study that looked at the impact of a patient education program on adherence to beta blocker therapy after a heart attack. These investigators found that the percentage of time that patients were covered by beta blockers improved among patients who received a patient education initiative or program versus patients who just received standard of care. In this study, which was a pharmacy-based patient education program, the investigators looked at what would happen to medication adherence for therapy for hypertension and for cholesterol management. And what they found was that after this pharmacy-led patient education program, medication adherence was markedly improved. And there was a significant, here we can see a significant improvement in medication adherence and a significant reduction in systolic blood pressure. They didn't notice any difference in bad cholesterol, LDL cholesterol, but they did show that increased control of blood pressure. So with that, I'd like to put out a few summary points. Poor medication adherence is a critical patient safety issue, contributing to high morbidity, mortality, and healthcare costs. Patient education strategies have the potential to improve medication adherence and healthcare quality. And then finally, a patient education program designed to improve medication adherence to clinician-prescribed venous thromboembolism prophylaxis is a good example of a feasible and successful intervention to enhance care in cardiovascular medicine. And with that, I'd be delighted to take questions.
Thank you, Greg, for sharing all those strategies. I can't think of a more appropriate individual to give this talk than you as chair of the NATF Education Committee. And I think it just shows how education is really at the center of everything that we do, and you pointed in some very positive directions. Questions or comments for Dr. Piazza? Dr. Sasahara.
I thought that was an excellent overview of the problem. And although the reduction of adherence from 49% to 29% is significant, 29% is still not a good number, right, of patients refusing to take prophylaxis. Now that we have the new oral anticoagulants besides warfarin, and these new oral anticoagulants have a rapid response, would they be the ideal patients to take these new anticoagulants?
Well, I think that's, that is one of the major points of the study that we had in our discussion, was that there's such an impediment, either anxiety or discomfort associated with prophylactic anticoagulants that are given by injection, that if we could somehow improve that by giving it in an oral formulation, we would boost adherence. And so I think we have now several oral anticoagulants that we would be able to test that hypothesis and see if the large impediment or the large reason for patient refusal is just the need to give a self-injection.
I see Dr. Ruff is here. Christian, you run a lot of large-scale trials testing novel oral anticoagulants. How do you get the patients to take the medications in your trial? And is what you do in the trial sort of the same as what we do in the office?
No, it's a great question. In clinical trials, this becomes a huge issue, because obviously the only way you can adequately compare an old therapy with a new one is if patients and subjects are actually taking the medication. And just like in clinical practice, even people who volunteer for clinical trials, the biggest thing that we find is patients don't take the drugs correctly, even though we spend an enormous amount of time trying to educate people to take it as prescribed and on a daily basis. And one of the things that we focus on, a lot of these things that Greg spoke about are critical, is having very simple reminders and calendars, and sort of always reinforcing how even missing 1 or 2 doses when you're dealing with either venous thromboembolism, and we do a lot of research in atrial fibrillation that use a lot of the anticoagulants, is critical. And taking the medication each and every day is absolutely important for preventing some of the sequelae. And actually, one of the things Dr. Sasahara mentioned, with the new agents, because they're rapid onset and rapid offset, actually compliance will be even more critical. And so I do think the new agents are potentially easier because they're oral and people don't need to get an injection, but making sure that people take them on a daily basis will be even more critical than Lovenox or potentially warfarin.
Thank you. Please, Benu.
I'm Benu Bigtelly.
Why don't you introduce yourself?
Sure. I'm Benu Bigtelly, currently working at Yale as a postdoc, but I've been honored to learn and work with NATF for a couple of years. Excellent talk, Greg. My question is if you can comment about educational initiatives in people who are not necessarily patient, like people who have long-haul air travels frequently or people who have a sedentary lifestyle. Are there educational initiatives for these people as well?
Yeah, I think that that's an important, there's patient education that we can do at the bedside, and then there's patient education that we need to do sort of in a more public forum. And I think that for the issue of air travel and the risk of venous thromboembolism, there has been some work in actually increasing the public's awareness of the risk of venous thromboembolism. If you turn to the back of a lot of your in-flight magazines, frequently there'll be, it's usually not a full page, it might be like a column next to like a few restaurant recommendations that they have, but they have a column about some exercises that one might do on a plane to help prevent venous stasis and reduce the risk of venous thromboembolism. I think that, while there haven't been clinical trials to show that that's actually what you should do on a plane, I think it's probably helpful. And at the very least, it raises awareness of this problem of venous thromboembolism.
Somebody's agreeing with you.
The most important person's agreeing with me, so.